Hello and welcome. Sabrin Barkoudah, Editor-in-Chief, Journal of Clinical Outcomes Management. Welcome. New issue, new science, new ideas, and most importantly, new scientific implementation science and quality improvement. Here with me, two authors. The first author is Nike Izmaylov. Nike is a fourth-year medical student at Vanderbilt University School of Medicine in Nashville, Tennessee. Nike, good afternoon.
Yeah.
And also looking over her shoulder, her mentor and the senior author on the manuscript, Dr. Chase Hendrickson from the Division of Endocrinology, Department of Medicine, also from Vanderbilt University School of Medicine, Vanderbilt University Medical Center in Nashville, Tennessee. Chase, thanks for your time.
Thanks for having us. We're excited to share with you some of the work that we've been doing.
Thank you, thank you. So maybe, Nike, to set the table and make sure we're teed up to hear how the project went and how the scientific conclusion been delivered. The manuscript, Improving Glucagon Prescription Rates for Individuals with Type 1 Diabetes. We do have a problem, clinically, the hypoglycemia. It's easy for any clinician, for any doctor, for any provider to add the glucagon, but we do not do that. So the clinical matter is there. Walk us through how you thought through it and how you improved the metrics, the key indicators for your study, and how that went within the walls of your institute.
Absolutely. So at Vanderbilt, we have the dedicated Eskin clinic, which specifically sees many endocrinology patients, in particular has a dedicated diabetes division, which has been really wonderful for our patients with both type 1 and type 2 diabetes. Dr. Hendrickson and I noticed that amongst our type 1 patients, type 1 diabetes, that many of them did not have active glucagon prescriptions, even though that is considered standard. It's very important in terms of their safety for them to have access to glucagon in case they have instances of hypoglycemia. Our rates were still, higher than what we see at many other clinics that don't have dedicated diabetes centers, but we still thought, the current rate that we're at is not sufficient. We really want to bump it up as high as possible to ensure that our patients are safe. And so we began to think about what possible interventions we can do in order to ensure that our clinicians are actively looking at their active glucagon prescriptions and prescribing them as necessary. We really analyzed what was going on that was causing clinicians to not be asking patients about the glucagon prescriptions or not be thinking about prescribing them. And in our interviews with many different stakeholders, from of course, the patients themselves, pharmacists, clinicians, the front desk staff, we really realized that a lot of the issues here were that the clinicians didn't feel like they had time during the appointments to really discuss that, because they were, of course, talking about other things that were more immediately pertinent to the patients and what the patient's problems were. And so as a result of that, we decided to try two different interventions. The first intervention that we tried was that on the face sheets, so physical pieces of paper that were given to each patient, the front desk staff would essentially write down a reminder about whether or not this patient had active glucagon prescription, to give the clinician essentially kind of an opt-in reminder right in front of them to ask them about the glucagon prescription and then to prescribe them if necessary. That unfortunately did not really raise the prescription rates as much as we would have liked. The second intervention that we tried that did really lead to a positive change was that we actually employed our wonderful pharmacists, part of our interdisciplinary team that cares for our patients, to look ahead of time through the electronic health record, determine which patients needed a renewed glucagon prescription or a new glucagon prescription, and to actually pen the orders ahead of time in our electronic health record. So by penning the orders, the orders basically already and teed up, the pharmacists had done their due diligence in ensuring that the order would be appropriate for this patient. And the only thing that the clinician had to do was then sign the order during the encounter. So this provided kind of an opt-out intervention where at the time of the actual appointment, when the clinician met with the patient and was then signing their visit, they would have to choose to sign or not sign that order. And so that really, we found that really improved our rates. And one of the reasons that we think the improved rates was number one, because our awesome pharmacists did like a lot of the work of thinking through what the prescription would need to be ahead of time. It really took a lot of that cognitive load off of the clinicians. The clinicians were more focused on, what they can do with their intuition, like as a clinician for that specific patient. And then the pharmacists were kind of on the back end working through the ensuring that the specific prescription was appropriate for that patient. And because the order was already there and pended, it wasn't the kind of situation where, unlike, for example, with the first intervention, that the clinician could go through the entire appointment and then say, oh, shoot, I forgot to ask that question that was written on the face sheet. But it was at the time of signing the visit, the clinician would say, oh, the order is already right here and signed. The path of least resistance is actually to go ahead and fill that prescription, or not fill the prescription, but to sign that prescription into an order. And the important part about this is that at no point were we forcing clinicians to prescribe for their patients or overriding their own judgment for their particular patients. They could always decide not to sign that order. But by offering the path of least resistance as the one that was kind of standard, about assuming that all patients with type 1 diabetes should at least have a consideration about an active glucagon prescription, it really raised our prescription rates. That's great.
Nike, what you said is a textbook being persistent, being resilient to make sure the best intervention would work. And to us and anybody who would work in healthcare, that's what we need. And for the viewer or who's watching, Nike is graduating medical students will hear, I will keep kind of the punchline to the end, but these are efforts driven by what she does in the clinic within the oversight of Dr. Hendrickson and his mentorship. Love it, the way you presented multi-intervention. And what resonated also with me is we're not forcing clinicians, we're just nudging them. Mental load, fatigue of all the alerts, and how we can get to the best care. Chase, you see that in your clinic. We would like always to reach 100% rate compliance, but as anything in medicine, it averages between maybe 20 to 40% on a good day, from medication compliance to prescription. Would you please share with the viewers your the results and how we can implement it at large? We all live in Epic or Cerner or one of these EHRs, and how can we get to the 100%?
Yeah, great questions. And like I said, I really appreciate the chance to share some of what we've been doing here. So my perspective on this is primarily from being the medical director for our diabetes clinic and trying to think, how can we support our clinicians as much as possible? I am hopefully preaching to the choir and certainly don't need to remind anybody who does primary care, and certainly folks who are in endocrinology or specifically diabetes care, of how many things you have to do to take care of folks with diabetes. It can be overwhelming, the checklist that you've got to go through, and that's leaving alone the issues of trying to get somebody's glucoses under control. You've got to remember all the different labs and their eye exam and their foot exam, and it just seems an endless list. And so it is not at all surprising that on anything like this that we look and say, man, we're not doing as well as we would like to do here. And Nike mentioned that some of our baseline actually was relatively good. And even with that, we were only doing a little bit more than half the time. So upper 50% range, about 58% at baseline of does somebody with type 1 diabetes have a prescription for glucagon. And so it was a little bit shocking for us to see that, well, that's actually relatively good compared to some of the other prescribing rates that are out there. But you're right, we want to push that as high as we can. Yeah, maybe 100% is not realistic, but boy, just over half is not where we need to be. So what we realized, and I think this is bread and butter QI type stuff, is thinking, hey, how can we take this off of the plate of the clinician? Our endocrinologist, our APPs who are in there, they have so many things that they need to do to take care of the patients. How can we take a more centralized approach to be handling this? And so that was the target that we did. We tried a few different approaches, but the one that worked that Nike described is using our pharmacists. So we have a great team-based approach here. And there were really the folks who were in our system who are ideally situated to be looking at that, to be running these reports from a centralized perspective, not to be waiting for patients to show up and doing it at the time when you've got many, many other things going on, but to look at our entire electronic health record and to identify, hey, where are we missing here? Where can we intervene? And doing it in a very systematic approach. And I think doing that using our team-based care, using a systematic approach, and then also leveraging other folks besides just putting something else on the provider's template to take care of. I think that was the real keys for success there. And so with that, we're really within just a few months of that second intervention where we used our pharmacists, we're able to pull those prescribing rates well up above 70%, which was for the project, which we limited to just a year in that initial work. Within a few months, got it up to that goal. So we'll soon be reassessing since several months since then to see how that has continued and if that has been maintained. But we're very optimistic that we built a sustainable model with the way that we've created this.
This is awesome work and really highlights that view from your leadership position where I am overseeing my clinic. I have thousands of patients coming through my clinic, but how I can get to that rate better, how we could do better of what we do. And it's not just the glucagon, it's really the totality of the care and leveraging the pharmacist-driven care delivery model. This has been fantastic. Thank you for sharing the highlights, the scientific entrees here. I would like to transition to one more topic, mentorship in medicine in QI. Here we have a medical student who wants to make a difference and a mentor and a leader in the field wanted to provide that opportunity. So maybe Nike, I will start with you. You approached Dr. Hendrickson and you said, I'm here. He showed you a paper. He said, we're right above 50%. I would like to see it higher. Tell us, just share your mentorship tips for our viewers, medical students, residents, which you'll become one very soon. How did you think about that QI approach and with the context of mentorship and that support you received?
Absolutely. I would like to also shout out here all the other awesome medical students who helped work on the project, as well as our two pharmacists. It was not just me and Dr. Hendrickson. We had an entire team of many of my awesome peers, third years and fourth years who worked with us. And the reason I bring this up here is that Dr. Hendrickson did an amazing job of teaching all of us not only how to move this QI project forward ourselves, but also how to coordinate given the nature of all the different medical schools teams. All of us were kind of working on this through a busy rotations. And so it was really awesome to see not only the mentorship regarding the QI aspect of it, but really the organizational aspect of it that was such a key to the project success. Something that I really appreciated about Dr. Hendrickson's mentorship was that he really allowed the students to take charge in terms of what we wanted to look at, how we were going to assess it, who we were going to talk to. And what his goal really there was to facilitate those conversations, to facilitate the connections between those students, and to really help us. So we would decide, okay, here are the people that we want to talk to. How do we reach out to them? He did an amazing job of nudging us in the right directions of saying, who else do you think it would be important to talk to? What other types of interventions do you think we need to start expanding our thinking outside of the little like clinician box that we had stuck ourselves in, and to start saying, what else can we leverage about the situation? For example, with the electronic health record, that was one of the thoughts that we had early as students of saying, how can we leverage this tool that we have? And many of our thoughts would have to do with like something that would require us to contact Epic itself and make changes to the electronic health record. And of course, that's a very arduous process. And one of the things that I really appreciate was that he helped leverage us thinking of saying, well, even if we can't contact Epic and make like a change to the electronic health record itself, we could still leverage it through a different means. In this case, ultimately, that led to the intervention of asking the pharmacists to append orders. And so that was really wonderful about the way that he was able to take the suggestions that we had and help to nudge us to transform them into more practical applications that ultimately led to the interventions for our patients. He also really led us in, as I said, coordination. So one key example of this is that as we had each team of medical students kind of coming in to as the rotations changed, he really led us through the process of maintaining a very complete record of what we had done so far, what our current thoughts were, what needed to be done next, and providing short elevator pitches to the incoming team to provide that continuity. So it wasn't just him leading the project, it was truly us students leading it, with him helping us provide that continuity throughout each of the months. And I really, really appreciated that extra look to not just focus on the project itself, which was also, really helpful, but to also step back and say, so in a project like this with so many different moving parts and so many different moving people, how are we going to facilitate the students themselves being the ones to coordinate and lead it, even though the team that is actually working on the project is changing over time.
Thank you for sharing. And I'm going to transition to Chase, but as you all know, and Dr. Hendrickson, he knows it because part of the training, clinical training in medicine, residency and fellowship is the QI curriculum. And with all these kudos, Dr. Hendrickson, and all this praise of your work, your leadership, you're busy, you have your patient panel, you have your fellows, you have your students, you have your residents, you have your clinical research line. Your thoughts about how we can augment this and bring more to the QI to improve what we do every day in the clinic and on service?
Yeah, well, I'd say, first of all, thanks to Nike for all her kind words. I'm always happy to take credit when other people do work and take credit for that. But I think what made this work and the way we have this set up is these projects, and we've done a few of these for several years now, are embedded in a rotation, a diabetes specific rotation that is offered as an elective to our senior medical students, or third and fourth year medical students here at Vanderbilt. And I think it has really given them an opportunity to put into place many of the QI training that they get. You mentioned that it's required training at many different levels. And so the students all came in with having received some QI training. And this was the perfect opportunity to let them put those excellent skills into practice. So as opposed to just being something theoretical, if they'd seen a little bit of, they got to take a real project, and it was a longitudinal project run throughout the year by different groups each month, but got to tackle different aspects of that. And so it was something that it was a real project, something that they were actually making change on. And I think that was helpful to be able to see that in different stages from beginning to end, and then asking Nike to take the lead and really thinking about, okay, now how do we communicate this? We've had success, we've seen some benefit, we found something that worked, but how do we actually communicate these to other folks, in particular in a way that can be applied to other systems that may not be the same as ours? And so that's been a great experience to be able to do that. And I think that's likely the best way to really make that a change, to really let people do work on real projects that actually lead to improvements for the patients that they are actually taking care of. And then in particular, to have the opportunity to communicate that in whatever form, whether that's a manuscript that you write up or a talk that you're giving or a poster that you're putting together, but to some way to be actually able to see that as an end product that you're sharing with others.
Thank you for sharing, Chase. And Nike, this could be literally a manuscript by itself about mentorship and structure and resources. So with this, we'll thank our authors and congratulate them on the scholarly work. Nike Izmaylov, student doctor, soon to be a doctor, officially graduation in a couple of weeks. Congratulations. And Dr. Chase Hendrickson, from Vanderbilt University School of Medicine, Vanderbilt University Medical Center. Thank you very much for your time, and grateful for your contribution.